We'll hear from, in order, Dr. Ron Kessler, who is a McNeil Family Professor of Healthcare Policy at Harvard Medical School, then Dr. Greg Simon, who is a scientist at the Kaiser Permanente Washington Health Research Institute, then Dr. Mark Reger, who's a chief of psychology at the VA Puget Sound, then Dr. Nav Kapur, who's a director of the National Confidential Inquiry into Suicide and Safety in Mental Health and professor at the University of Manchester, and then Dr. Suzanne Bird, who's an investigator clinician at the Mass General Brigham healthcare system, and for many years has been the director of the acute psychiatry service, which is effectively psychiatric emergency department at Mass General Hospital, just stepping down this past week, which is great for us because she can now join us to give us frontline clinicians' perspective on a lot of these issues, both opportunities and potential challenges. So with that, I will stop talking, and Jordan and I will turn the program over to our speakers, starting first with Dr. Ron Kessler.
Thanks, Matt. It's nice to be here. We each only have 5 minutes, so I'm only going to make one point here. And that is that although, as you said, we're all interested in using machine learning methods to predict who's at risk of suicide. In fact, there are three ways in which AI, machine learning, can be used for suicide prevention. And we underuse two of them. The first is with trial emulation. Um, and it's possible to emulate trials that are difficult to implement for ethical or practical reasons, like immense samples are needed to do an experiment to be able to see does an intervention have an effect in preventing suicide. But accurate trial emulation requires detailed balancing and doubly robust estimation that's facilitated with AI methods. There are three ways in this can be done. First, you can do an individual level comparative effectiveness study. So our colleague Miguel Hernan here at Harvard is with his group doing a really interesting study on the effects of lithium for suicide prevention, a topic of considerable clinical interest and controversy, with an enormous sample from the Veterans Administration. And emulating an earlier trial to see if you can get the same results and then expanding it beyond to increase statistical power, look at subgroup effects. The second is individual level regression discontinuity design. So the REACH vet intervention in the US that some of you are familiar with, 2016, a model was developed to figure out who are the high-risk vets for suicide, and intervention has been put in place since then in that small percentage of the population thought to be high risk. But it's possible to look at changes in the suicide rate in that high-risk group from earlier years to current compared to lower risk groups. So using a before-after case control difference and difference kind of design that, again, is facilitated to make quasi-experimental evaluations using machine learning. And the third is something we don't really think of very much, and that's simulating policy experiments. There's a really interesting piece of work done by our colleague Jose Zubizareto, who's going to be offering a presentation here in a couple of months, looking at the effects of state-level no-fault divorce laws, allowing women more easily, at least in financial terms, to escape abusive marriages, and the effects of that on the suicide rate. And he looked at time series in states where that was either put in place or not put in place and changes in the suicide rate, and came up with pretty definitive evidence showing that that law led to about a 7% reduction in the suicide rate of women of married age in those states. So in each of these three cases, results could be used either for facilitate genuine trials or to expand in the case of policies to other states. The second way MI can be used is the one we most think of, which is to who's the ones at highest risk. This can help determine which subset of patients get an intervention, as in REACH Vet, or in models like Greg is using to target outreach after safety planning. It can be used to narrow the denominator for a true experiment. So Lauren Weinstock's 3C experiment in VA in Rhode Island, where she's looking at a machine learning model to predict risk of suicide after hospital discharge, focusing on the 10% of patients who account for roughly 50% of all those post-discharge hospitalizations. And she's doing a case management experiment just in that 10% because it's not cost effective otherwise. But the question is, can she show a significant reduction that makes financial sense, which is one of the concerns with machine learning models. It's also possible to investigate differential response in an individual treatment. For example, which suicidal depressed patients are helped by esketamine? Our colleague Joanne Camperdon is doing a study of this sort. What's the best thing to do? This could be used as a possible first step in defining a denominator. So, for example, randomize esketamine versus treatment as usual to a subset of refractive depressed patients, only that subset thought to be helped by esketamine. And the third way of using machine learning is with precision treatment. And that is, in effect, putting together the first two things, using counterfactual logic to simulate specifications in which we investigate the subset of patients whose outcome we expect to be optimized with treatment A or treatment B. Our colleague Brian Marks is launching an experiment of this sort right now based on an earlier precision treatment model using machine learning in VA to say when a suicidal patient presents to the ED, should they be hospitalized or should they be treated as an outpatient? And it turns out that there's some evidence that suggests from this model that a subset of patients really need to be hospitalized. It's going to save their lives. There's another subset of patients, though, that hospitalization actually hurts. And it looks like from the simulation that by optimizing the decision about who to hospitalize, we could both reduce suicide by about 15% among these patients and also reduce hospitalizations by about 20% dealing with the boarding crisis. So Brian is in the midst right now of using that machine learning based precision treatment clinical decision support analysis for preventing suicidality to conduct a two-arm experiment where a random 50% of patients get treatment as usual, another 50%, the decision about hospitalization versus treatment as an outpatient gets guided by the machine learning model. So I will stop with that. There are obviously lots of ethical and practical and fairness kind of issues that arise in all these things, but I assume some of those will be addressed by others. So that's it. Thank you.
Wonderful. Thank you so much, Ron, for kicking us off so effectively. And next up, I will turn the microphone over to Dr. Greg Simon.
Okay, here we go.
Perfect.
And okay, thanks very much. I'll be focusing mostly on, in Ron's scheme, the sort of middle or second use of these kinds of models, and that is to target outreach or prevention interventions. To make 3 points. The first of those, and I frame it as a question, have we reached sort of peak prediction from health records data? And as will be obvious, my answer is I think yes. What we've seen, our group and many other groups have now developed models to predict either self-harm in general or sometimes suicide death from health records data. And I think what we're seeing is those tend to converge around a sort of AUC or C statistic for classification accuracy of about 0.85 with remarkable consistency. We can argue about whether AUC is the best metric, but at least it's one that's comparable across populations with different base rates. So everybody seems to be bumping up against this ceiling. I think it's also fair to say that these models pretty consistently identify not only the expected predictors, but predictors which are relatively stable. Obvious psychiatric hospitalization in the last year, a self-harm event in the prior 6 months. At least in our hands, attempting to dig deeper with sort of more complex temporal encoding, encoding sort of very complex possible time patterns and predictors over the last 5 years, or moving to much more complex modeling methods, shifting, say, from the sort of old-timey penalized logistic regression models to random forest to sort of multi-layer, more complex neural networks, at least in our hands, and I think it's fair to say in some other people's hands, has not necessarily performed better. And there's even some risk in trying to dig deeper. I think we've seen some instances of, I'll say in our work, we very intentionally used relatively sort of coarse features or predictors, lumping together sort of broad categories of mental health diagnoses or mental health medications, with the idea that sometimes the specificity of diagnoses may be misleading. That if we were to concentrate, for instance, on whether, the diagnosis was an F32.9 or an F32.3, what we might be selecting for is being hospitalized in a particular facility where the electronic health record tends to favor one code over another. And I think this is one reason why some models that have allowed to dig deeper into very fine-grained predictors have actually not traveled well. One cautionary note is this sort of overfitting may not be the best term, but this sort of discovery of facility-specific idiosyncratic prediction relationships will not be discovered by some split sample process when you're operating within one healthcare system. You'll only discover it when you move to a different place. So I think we probably have reached peak prediction from electronic health records. So next point is what else could we use? Health records data at this point don't tell us much about some very important risk factors for self-harm or suicide, negative life events. Although many health systems have started to encourage coding of social determinants of health or adverse life events, that coding is still relatively sparse and pretty selective. And most important, those diagnoses would only be coded in someone who comes in and seeks care. They would not be coded in people who are not receiving any kind of mental health or medical treatment. Some health systems have begun to screen for these, but that screening is still fairly sparse and selective. We certainly could learn about those important life events in other ways. One obvious example that people on this call have been involved in and are familiar with is, say, in service members where, a branch of the service is not only one's healthcare provider, but is one's employer and sometimes even one's criminal justice system. We could identify and link data on life events. One that we've been very interested in is using data from data aggregators, LexisNexis, TransUnion, who not only are used for credit ratings, but actually have a lot of information about life events people experience, like marital separation, divorce, incarceration, arrest, and so on. We've done actually a lot of survey work with health system members asking us about whether this is acceptable. It's interesting. We hear some pretty broad acceptability. What people tell us is it would be okay to use that information if it were helpful, but a small proportion of people seem to be strongly opposed regardless of how useful or helpful the information is. So that, I think, poses a real challenge about if we're trying to do some population-based prevention, how do we accommodate people's wishes and preferences when a small group of people are quite opposed and the majority think it's a good idea? We've also encountered some significant reluctance from health system leaders about using this information, primarily about reputational risk, although it's interesting, as you may know, most large health systems already have and use these sorts of data for business purposes. So the concern, I think, more might be the curtain will be pulled back and people will realize that health systems have a lot more information about you than you had previously thought. My third point is about interventions, and I think we want to be fairly cautious about where we actually have data about the effectiveness of interventions. We certainly have strong randomized controlled trial data supporting the effectiveness of specific psychosocial treatments, but it's important to realize most of these data come from randomized trials of people who are at high risk. The typical would be people who've recently been hospitalized after a self-harm event, and also for people who are seeking treatment and volunteer to participate in a clinical trial of a prevention intervention. So we're studying these interventions typically in a pretty select population. There are some of those caring message interventions, which, as you may know, are originally developed for people who were not seeking or even avoiding treatment. Interestingly, I think the more recent data on caring messages is less encouraging than some of the earlier trials. That may just be the usual difficult to confirm some small early studies, or it may be that these days people receive so many messages that pretend to care about them that any benefit of caring message interventions has been blunted by the information onslaught we all face. We'll hear more. I mean, we do see moderate interventions from moderate evidence for pre-post designs, REACH-VET evaluation being one, another, our sort of mental health research network zero suicide implementation, suggesting that some of these population-based interventions can have broad effects. But my main point is I think we need to be careful about extrapolating from some of that randomized controlled trial evidence to people who are quite different. And this is a little bit different point than you hear, for instance, in the cancer screening and prevention space, where we talk about sort of length bias. You know, the classic example there being that prostate cancer detected by screening may be a different animal from prostate cancer that presents clinically, and that it is slower growing and maybe less lethal. Here, it's not so much about the sort of severity as much as is people's willingness to engage in intervention. And that may be very different for people who've been detected by one of these prediction models. So those are my 3 points. Now I'll pass the baton.
Great. Thank you so much, Greg. Really, a lot of really interesting questions hit in there. So a lot to discuss after the speakers all present. And next we will transition to Mark.
All right. I really appreciate the discussion, and Greg teed up nicely the topic that I'm going to focus on as a set of questions that I think we have moving forward. First, I do want to, my slide's not moving. Let me try this button instead. There we go. My discussion is just my own thoughts and opinions. I'm not representing the VA's official positions. I'm not representing the ReachVet program today, just sharing from my experience and some preliminary studies. But I want to focus on stakeholder perspectives, on the implementation of an intervention based on a predictive model. And Greg shared a little bit about, well, what do we know about data use? And we have looked at some preliminary data for 2 groups that I'm going to take the 5 minutes on today, patients and clinicians. There's other key stakeholder groups for sure. Leadership was mentioned earlier, but we'll just introduce some themes here. I'll mention that these are just quick and dirty preliminary studies based on one program, based on data collected at one facility. They're really, I think, helpful for hypothesis forming and discussion of what we might consider as we move forward as a field. Regarding patients, so we when ReachVet was rolling out, I had a lot of questions about how our veterans were going to react. So thinking about who was likely to get identified, we went to our mental health inpatient unit and used a standard VA script for how you would introduce ReachVet to veterans, and we wrote 2 other ones that we thought might be helpful. So that's why you see 3 bars here. There are 3 different scripts. It turns out it didn't matter what we used. The bottom line here is that the veterans were quite accepting of this idea of working on interventions for suicide prevention based on a predictive model. Over 70% rated each script as caring, helpful, informative, and encouraging. We did see these outliers though that Greg is talking about. What do we do about those folks who found the idea very much uncaring? Like, what do we do about that as a field, and how do we make decisions based on that? We did ask them in a qualitative part of the study, what advice would you give clinicians who are contacting patients? It was interesting. So over 50%, we got 70 responses out of 102 people in this study. Over half of them talked about recommendations clinicians should be courteous and patient, respectful, caring. It was all patient-centered kinds of recommendations, soft skills kinds of stuff. Most were not talking about the predictive model piece. But again, some did. And I've got some examples here. If the discussion moves in a certain direction, I could read a couple of them. But, about 8% disagreed that the program respected their privacy. 7% said that they would feel more hopeless after the discussion. So this is a challenge for the field. For providers, we did some preliminary work doing two things. We talked to the clinicians who are working on the ReachVet program, and we did a survey. This is a very small sample, 35 clinicians responded. It was a 47% response rate. And then we followed that up with qualitative interviews with folks who were willing, which ended up being 12 clinicians. So just really dirty preliminary kind of data. But in the survey, 54% thought that it significantly increased their work. 71% thought that their time spent on the program was not well spent. 49% thought it increased their liability. So you can see sort of these themes that I've outlined on the slide coming out in the data. My hypothesis is that patients are going to be more accepting of these kinds of interventions than I probably would have predicted. And I think we are going to need to invest significantly in clinicians. I think the themes that we're seeing here are probably what everyone will need to pay attention to. I think the intensity of the concerns and how well they're addressed will obviously vary from program to program and the implementation and the work that is done. The thing I will say is that 60% thought that ReachVet was consistent with their values as clinicians. So I think there's some reason for hope that clinicians can find the value in this. But I do think that this is an area that the field really should probably invest in, based both on my experience in our facility as chief of psychology as it was implemented and based on some of our preliminary data. So I will stop there and look forward to the discussion.
Excellent. Thanks so much, Mark. Really hitting on some of the key clinical issues as we get into taking these models and moving them to implementation. A lot of complicating factors come up. So it's a really nice transition into that segment of the discussion. And now we'll turn it over to Dr. Nav Kapur.
Hopefully you can see that, Matt. Delighted to be here. Greg, you won't remember this, but many years ago, you took me to one side at a conference and you said, look, good talk in many ways. But the thing you have to realize is the US is a very different place from England. So I'm particularly delighted to have been invited to this webinar as the only non-American panelist. And apologies in advance if some of what I say sounds like it's coming from an alien mental health universe. Now, this kind of argument is almost kind of irresistible. And even as I'm kind of putting it up here on my screen and reading it, I find it hard not to agree with it. So, you know, the argument goes, look, we haven't been very good at predicting suicide. Suicide's really complex. Machines are fantastic at dealing with complexity. You know, therefore, machines are the answer to the suicide risk assessment problem. You know, there are some logical missteps there, particularly between the first and second bullet points and the third and fourth. But, you know, we'd all love this to be true. It's almost irresistible. And I think therein lies some of the problem. The literature, my reading of the literature is it's large and growing larger by the second, and it's also messy. Now, the big exception to the messy literature is some of the brilliant work done by my co-panelists. I'm not just saying that, I've highlighted their studies as exemplars on previous occasions, but the rest of the stuff, well, there's loads of kind of cross-sectional stuff out there, people using different models to model different outcomes in a whole variety of different, you know, inpatient community settings, using lots of different methods. Much of the work isn't real world, so people who develop these clever models but not apply them in the real world and not see what difference they make. It might just be me, but a lot of it I couldn't understand what on earth some of these studies did. You know, unclear reporting, difficult to follow. I really like Mark's talk because a lot of the studies out there have very little of the kind of patient voice in there, very little lived experience, and a lot of the field, I'm afraid, is filled with kind of hubris and a bit of overpromise. And I think there's a disconnect, and I feel this disconnect as a researcher and clinician. I feel it within. It's the disconnect between, you know, elegant, wonderful research designs and epidemiology and the clinical frontline. You develop these models, you know, how applicable are they to the frontline? Now, to my mind, the predictive ability of the machine learning models is maybe a bit better than traditional models. But if it's better the improvement is incremental rather than transformative. And what that means is all the problems with, that issue of predicting rare outcomes, that still applies. So, some of our work that you'll be familiar with, some of these risk assessment tools being no better than chance. The other thing about some of the risk assessment tools is even in a high risk group, so people who have self-harmed, who've engaged in suicidal behavior, the positive predictive value of these scales is about 5%. What does that mean? That means if I rate 100 people as at high risk, only 5 of them have the outcome of interest. Now, I know, some people have an issue with positive predictive values. I think clinically they're quite intuitive. I quite like them in some ways, but I'll absolutely take Ron's point and Ron's kind of work about net benefit. So his point is, well, it's all about whether these things do more harm than good. And you can have scales that have much lower positive predictive values than that, as long as you have almost universal low-cost interventions that don't have any side effects. If you give that to a whole bunch of people, the net benefit is going to outweigh the, if you like, the disbenefits. And I'm kind of persuaded by that. The problem is, for me, I think in suicide prevention, those interventions that can be universally applied at low cost with low side effects don't exist. So it's a problem with the interventions rather than the risk assessment themselves. And this is something that I don't think is often talked about. It's the disbenefits of a culture that is risk focused. We're obsessed with risk in mental health. Risk assessment is an industry. When we went round to every single mental health service in the UK, we said, give us a copy of your risk assessment scores, tools. We got, out of 60 services, we've got 156 different tools back. In a third of cases, these were tools that the services had made up themselves. And it's a distraction. Some of this kind of shiny new stuff, I think, is a distraction. It's a distraction from the clinical reality, at least in the UK, of fragmented services. So there's a report on our kind of self-harm services by the Samaritans. It's a distraction from services that in many cases are, almost at breaking point. We're talking about shiny new models. It's about the basics of services, but it's also a distraction from the individual clinical encounter. So, using these things, clinicians ignore the relational aspects of the assessment, and they end up treating the scores rather than the needs of the patient in front of them. One of the other big problems, for me, the biggest problem is the one of exclusion. If you rate a bunch of people as at high risk, you're rating people at lower, moderate risk. Those people, to a large extent, certainly in the UK, get excluded from treatment because they're big groups. That's where the greater number of adverse outcomes are. It's the old population paradox argument. The other thing for clinicians is, may provide false reassurance and does kind of foster this culture of defensive practice, which at its most extreme, actually, we've talked to clinicians, involves almost a retrofitting of the risk assessment to flip the clinical decision. What I mean by that is, someone justifies the decision not to admit by saying they were low risk. So this retrofitting and this defensive practice. I think we're much better off not using all this stuff to try and predict outcomes. What else can we do with it that's much better? Informational continuity, what do I mean by that? That means, different electronic healthcare records talking to each other. So if a patient goes to my local acute hospital, their mental health records can be easily accessed, the systems talk to each other, but also that the notes are accessible. So if you're seeing someone in the ED, you can use some of this stuff to actually extract the most salient stuff in the form of a kind of clinical summary, and some people in the UK doing some work on that. The other thing is knowledge support systems. I think delivering the information that clinicians need in real time in the clinical encounter could be really helpful. So I'm a great fan of guidelines in the UK. You've got patient information, it kind of flags the relevant bits of the guideline, may flag relevant research, patient outcomes from that service to help guide your decision making, maybe even modifiable factors. These things can help, I think, more, in a more robust way. Just to finish, I'm hoping that Matthew and Jordan are going to keep the recording of this talk on their website for a while. The recording of this session on their websites for a while, many years, in fact. But I do worry about future viewers looking at this and thinking that some of the discussions we're having today about prediction are kind of obsolete. They'll be puzzled that we're using these resources at our disposal to try and predict these in statistical terms, rare outcomes, rather than using their technology to help patients get more timely, effective, and appropriate treatment. Thanks very much.
Great. Thank you so much, Nav. Really nice drawing out of the big challenges involved and where the rubber of the science hits the clinical road and how these actually get implemented and what we actually do and how we use them. So really appreciate that that perspective. And that brings us to our final speaker, Dr. Suzanne Bird, who's going to give us that clinician scientist perspective.
Thanks so much. So my career has been spent primarily in the emergency department setting, so that will inform my thoughts about how these kind of machine-based tools might be integrated into practice. Psychiatry is a very qualitative field, as we all know, but in the emergency department, this is particularly true. There are very few evidence-based guidelines, but clinicians are expected to assess and manage quickly acutely distressed, symptomatic, and at-risk patients. Volume and acuity are high. We use whatever information is available to us to make rapid decisions that have significant impact on patients' immediate comfort, safety, privacy, and civil liberties. The information available to a clinician at any point in time is highly variable and subject to unpredictable change. Thus, clinicians are constantly synthesizing data, both objectively and subjectively, using their judgment, I want to emphasize that word, to formulate an assessment and plan, negotiate it with the patient, document it in a medical legally responsible manner. I liked the retrofitting notion. There's obviously appeal to the prospect of new tools that could add accuracy and reliability to these kind of dynamic clinical encounters, but I think it's hard for most clinicians to imagine or accept the idea of a process where their judgment might not be the ultimate deciding factor. ED psychiatrists see a broad range of presentations, but evaluating suicide risk is the bread and butter of what we do every day. Patients, families, our medical colleagues, law enforcement, and society at large, at least in the United States, look to us to assess and protect the safety of individuals, either self-identified or identified by others as potentially at risk of ending their life. I just want to stress that I said assess and protect. Most psychiatrists know intellectually that we're statistically unimpressive at predicting risk, yet we're very aware that it's our job to try to protect people from self-harm, at least in the short run. To reconcile this tension, I think most emergency psychiatrists largely avoid trying to predict suicide. Instead, we focus our energies on trying to prevent it from occurring imminently to the patient in front of us. Our primary job is to try to identify high-risk patients, lower that risk as best we can, either during the ED visit and or through referrals to post-ED treatment. So when thinking about the role of a clinical support tool in this process, I think most clinicians respond with a combination of keen interest and deep skepticism. Interest in having access to potentially more reliable data, skepticism that any tool based on patient report and the EHR can capture the nuances, the fluctuations, the environmental factors, the inter and intrapersonal variables that lead people to decide to end their lives. For example, how does a machine-based risk score integrate with my gut reaction about a patient I'm sitting with? The intuitive sense based on, I hate to say it, 40 years of evaluating patients, that this person is or isn't imminently unsafe today. Some of you may argue that a machine-based tool's conclusion should trump clinical intuition, but psychiatrists are trained to use our personal reactions to patients as important data, and that's a tough thing to argue them out of. How can a machine-based model take into consideration the family member who says, "This is the worst I have ever seen them. I am really afraid they're going to die"? Or the outpatient provider who says, "I have never been this worried about this patient. I don't feel safe managing them." And then there are the systemic challenges, which we haven't mentioned, to considering discharging a potentially suicidal patient who may have been assigned a low score on the risk calculator, but may not have any realistic community-based dispositions available to them. We have a dysfunctional and disparity-ridden health insurance and healthcare system, and those things conspire to make inpatient hospitalization often the most timely and reliable plan available to us. To facilitate the discharge of a patient deemed to be at lower risk, we need outpatient services that are available immediately, or at least acutely, and without a waiting list, and regardless of the patient's insurance status. And the patient has to be willing and able to participate in outpatient care. Discharging someone who insists that inpatient hospitalization is necessary to keep them safe, alive, even when we believe them not to be at imminent risk, can be difficult and anxiety-provoking, even for seasoned clinicians. Many clinicians are also skeptical about the reliability of both the data in the EHR and the information obtained from patient surveys. We know how inaccurate medical records can be because we contribute to them. We see the errors that get perpetuated again and again throughout time in patients' records. We also know that patients can and do hide and distort details about their lives and subjective experiences. Clinicians worry about the accuracy of tools that are based on these data sources and don't really understand how models might account for those inaccuracies. And we worry about the potential unintended impact of having these tools become part of patient records. What is the potential liability impact if clinicians do or don't agree with the risk level assigned by a tool? In part because suicide is such a rare event, clinicians are personally devastated and often deeply shocked when it happens to a patient they have seen. Completed suicides also represent the most common reason for psychiatrists to be sued, and being involved in a lawsuit, regardless of its merits or its outcome, is lengthy, demoralizing, and can have a profound impact on a clinician's life. So including new tools into practice that aren't fully tested, but may be intended to influence medical decision-making, can be very unsettling in terms of possible impact on medical legal risk. So I've raised a lot of questions and concerns from the clinical perspective. I want to end by saying how exciting it is to know and be part of the work that's being done to improve the reliability of risk assessments, and inviting the substantive involvement of clinical staff, as has been happening consistently at our research site, does give me confidence in the ultimate success of our efforts. We need to do better at this. We want to do better at this. Together, hopefully, we'll develop tools of true value for our patients and the clinicians who treat them. Thanks so much.
Amazing. Thanks so much, Dr. Bird, for that really, really valuable perspective. And thanks again to all of our speakers. This has been as amazingly helpful as we hoped it would be to hear these different advances and perspectives and opportunities and concerns. So at this point, I want to open it up to our panelists. We've got about 20 minutes left to raise a hand and respond to things that other panelists have said, ask any questions. I also want to, I've been doing a lot of talking, invite in my co-director, Jordan Smoller, to ask any questions or introduce any comments he has. And there's a few questions coming in the Q&A box. I want to remind the audience to insert any questions you might have there, and we'll get to those as soon as we can. I see that.
Matt, let me, I'm going to take a prerogative to, and I see Greg's hand up, and I suspect it may be relevant to what he may be commenting on, which is that the issue that keeps coming up here, I think, is the crucial one about, let's say that models do well, and maybe they do as well as they could do now, and maybe statistically that's better than a clinician does, let's say. The question really is, how do you, if you accept that they have a role, how do you integrate them into the clinical workflow? Where does the clinician go in the loop? And that is, I think, what Suzanne was talking about, what Greg has written about, as have others here. And part of the issue, I think, that maybe there's a little bit of a straw man in the assumption that these models would be sort of dispositive or acting alone. I don't think anybody's intending or contemplating that there would be no clinician. We know from, as was alluded to, Ron and others have pointed out, the positive predictive values that we use in other areas of medicine are often lower to make certain decisions, especially about screening, than we're talking about here. And so I guess the question I want to drill down on a little bit more is, what do we think about, and do we know anything about how we put the clinician in the loop? And as I'll just add one thing that Suzanne, you were sort of alluding to, it's sort of the clinical, I'm a clinician seeing patients as well, that clinical intuition that is really powerful. And yet, when you think about what is it that's leading you to make this decision, in some ways, very much like an AI model, you're a black box, right? It's hard to articulate in many ways, right? But it's a very powerful prediction. So, okay, let me open that to discussion here. And maybe, Greg, do you want to lead off? Is that, I suspect?
Yeah, sure. And that's, in terms of the practical, and I didn't describe that, but, I think, when we, chose to implement this in our mental health clinics at Kaiser Permanente, Washington, a lot of the concerns that have been raised were very much top of mind. And, what that led to was the idea that we would use these models to deliver a prompt to mental health clinicians at the time of a scheduled appointment to say, this is a person you need to pay more attention to. And quite literally, what happened was in my schedule view, when I start my day of work, there's an extra column in my schedule view that says needs risk assessment. And that column, this was a direct suggestion of one of our clinicians. That column needs risk assessment can take two values. One is a Y, meaning yes, needs risk assessment. The other is blank. There is no value of no. And this is, one of our clinicians telling us, you should never tell us that someone is safe. You should only tell us who are the people we may need to pay more attention to. It's also been very interesting to me as a sort of user of this system that I helped develop when I am surprised. How often is it I see that why when I say, I didn't think so? And invariably, because the models we've developed have no deep magic, they are not discovering something that I never thought of. They are, however, reminding me of something I forgot. And the typical scenario is someone who has lots of indicators of risk, has had previous self-harm events, been hospitalized, but for the last few weeks, they've looked really good. The data tell us that looks very good is deceiving, actually. And I think that's an empirical question, which to my mind is answered. That those risk factors are stable and enduring regardless of how someone looks today. And I need to be reminded of that because otherwise I will be misled by how someone looks right now.
Thanks, Greg. Nav.
Yeah, no, just a quick response to the clinician as a black box versus kind of risk assessment tools. I mean, we looked at this in the real world in the UK, not with machine learning models, but with the best available kind of, if you like, suicide risk assessment predictors there. For the clinicians listening, reassuring news, you were the best predictors. The only problem was that the patient putting a cross on a 10-point scale wasn't far behind you. But you were better than the suicide risk assessment scores. But even then, the predictive values of clinician assessment were pretty rubbish, really. And I suppose my suggestion would be actually to move away from why do we need to say this person, we think this person is, at risk of suicide versus not. Why do we need that? Why instead I think using it as prompts, absolutely fantastic. Using it as real-time adjuncts to clinical care, absolutely fantastic. But why are we so obsessed with kind of prediction? Why have we almost allowed this myth to propagate?
Thanks, Ron.
I think the big issue here in the risk prediction piece of things is to say at a certain point, we intervene, and at another point we don't. And if it's possible, Nav had talked about a low-cost intervention that you give to everybody. When you figure out whether somebody has fluoride in the water, you just put it in the water. It's not like some people get it and some don't. Everybody gets it, On the other hand, if you think about open heart surgery, you don't give that to everybody. There's sort of at a certain point where you make a decision, right? And you decide at the point where you think the risk-benefit ratio tips in a direction where it's clearly the case. And that's what the idea of net benefit, as you mentioned, is there. So a good example is we're working in hospitals now, in VA hospitals, where we are providing intensive case management to people after hospital discharge, because in the first 3 months after discharge is this high risk period for suicide. There's that sort of transitional risk. And you can reduce that by really holding their hands. We say, here's your case manager, Sally, and we introduce them to you before you leave the hospital, and they have a conversation. And my name's Sally, here's 24/7 my phone number, and we just hold their hand. We can't afford to do that for everybody. However, we have a model that says the 10% of people in the hospital who we flag account for about 50% of all suicides. We're right now in VA doing an experiment where we're only going to that top 10% and randomizing them either to get this something extra or not. And we're showing, it looks like in preliminary data, that we are in fact reducing the suicide rate. But we're doing it in a way that actually is cost effective because instead of doing it for 100 people to prevent 1/10 of one suicide, we're doing it for 5 people and preventing, and then all of a sudden it works. And that's what we do all the time. We do all kinds of tests and we decide, Greg's example from way back when, when you have a total cholesterol above something other, you get a statin and you don't at another time. And um, I think one big thing, and then I'll shut up, is that we don't in these models typically think about what's the target population and what's the intervention. And so, do we set a decision threshold in terms of what the intervention is? Chris Kennedy, who might be here right now, is doing a really interesting thing at the moment in the VA where he's looking at firearm suicide versus other suicides. And it turns out that there are very inexpensive interventions available for firearm suicide, locks and things like that. There's sort of a quick thing that are unplanned. Most people with firearm suicide, they have not had a prior suicide attempt. They do it and it works, kind of. So it turns out that the cost effectiveness ratio is that it might be 5 to 10% of people we intervened in that. Whereas for the more clinical intervention, you only intervene with 1%. But you have to think carefully about what it is you're doing. And then all of a sudden it kind of makes sense. It's sort of, I think, relatively non-difficult to make these decisions.
Great, thanks. In order of hands, Greg and then Nav.
Sure. And I just, one point I didn't respond to that, Nabe, that was really important was you have to think about, the intervention that a prediction model might be driving and what harms it might cause. When we started this work many years ago at KP Washington and talked about implementing these programs, one of the obvious, interventions might be someone who is identified where this little flag shows up and doesn't show up for an appointment. You probably should call them rather than just wait for them to reschedule. But the question is, how far down that cascade does one go? And there is, and I'll express an opinion here, an unfortunate tradition in the mental health field of if people don't take your calls, you send the police to their house for a so-called welfare check. Ironic air quotes, very much intended. We actually, had to get a pretty firm commitment from all of our clinical leaders that this model would never be used to send armed law enforcement to people's homes. And we said we will not implement this if that is a possible outcome. The idea being that there is a potential harm, that can come from identifying people at risk, and we just need to make sure by matter of policy that that does not occur.
Thanks, Greg. Nav and then Suzanne.
Just very quickly, just agree with both of you. I think probably Matthew and Jordan are a bit disappointed we're kind of agreeing. I think they were probably expecting you probably wanted a bit more
This is
spark.
great. This is great.
But I think for me it's about the interventions. I absolutely take Ron's point. Really a big fan of the net benefit stuff. But I'm talking from a UK perspective, and I understand it's kind of patchy in the US. Some places really good, other places not so good. It's about the availability of those interventions. And I think, Greg, that's a really profound point about who gets into RCTs and does that reflect the clinical real world and the evidence from RCTs being transferred to the real world. And I just thought actually it was such a neat inversion of the evidence hierarchy. We're always taught RCT systematic reviews at the top. Actually, what you may be saying is some of those have less real world applicability, and some of that observational stuff that's traditionally been poo-pooed in epi and research methods, that could really help us here.
Great, thanks, Nav. And to be clear, I am super excited about points of agreement. We're hoping that this would not be a debate, but really a way for us to get through and have deeper discussion than we can have in the pages of scientific journals and figure out the best ways forward. So this is fantastic from where we sit. Suzanne.
I raised my hand when the issue of sending the police to somebody's house came up, because I think that's a really important thing to talk about And Matt, you and I both remember a previous research study where when the research associates were calling people to do follow-up surveys and they received answers about potentially active suicidal ideation, those would get funneled to me as a clinician to then decide, do we have to call 911, or do we have to get this person to an emergency department? And I just want to bring up the geographical and even sort of microclimate variability in how societies and law enforcements and even courts in different parts of a state, not to mention different parts of a country, not to mention different countries, react to these situations, and how much obligation is foisted upon or is allowed to be released in terms of clinicians who receive potentially worrisome information. So really interesting point.
Yeah, and really tricky issue. Mark.
Yeah, just listening to the discussion, I was reflecting a little bit on the importance of the word prediction in people's different discussions and frameworks and understandings. And certainly from the implementation side, I think that word prediction is really, really important. Clinicians have been talking for a long time about, we don't predict suicide, we assess risk, because from a liability perspective, they're emphasizing, I can't predict suicide. No one should think I can predict suicide. I don't want to tell anyone I can predict suicide. And from a statistical perspective, we're talking about prediction from a very different perspective. And I think that does cause some tension between the stakeholders. And there may be room for clinicians to see how they have been predicting suicide for a very long time. And there may be room on the machine learning side to think about, do we really need that word prediction, or are there other ways to talk about it?
Yeah. Great. Very good point. Thanks, Mark. And Ron has a hand up, but is on mute.
Thank you. A couple of half points. One is Greg said that, I think that's a really important thing to say, that, these models don't really tell you anything we didn't know. It just reminds you of things that we forgot, which is kind of interesting. But it is the case that sometimes information gets pulled in. The case of LexisNexis, which we're using too, Greg, you don't know in your electronic medical record that somebody got divorced or they live in a neighborhood where there's a high crime. So there is, and that stuff makes an enormous difference. In our studies of who gets hospitalized and who doesn't get hospitalized, we found an interesting thing, and that is that homeless people are much more likely to get hospitalized when they have a mental health problem. And it turns out they have a lower suicide rate. Being a homeless hospitalized person, is a strong predictor of not dying by suicide after discharge. Why? Because you get hospitalized at a much lower level of acuity because you're homeless, right? They give you a bed. So it's an interesting little, stuff that you don't think of normally. But to the point of a prediction, this idea of precision medicine, of the fact that there's sometimes we have to make a decision, and we make a decision under uncertainty. And the question is, what's the best one? We're not living in the 0.05 level of significance world. We're living in the 0.50 real world. If it's 50-50, I don't know what to do. If it's 49-51, I'm going with the 51, And so Joanne Camperdon's work of looking at suicidal refractive depressed patients that are just not responding to other stuff. What do you do? And there's these heroic treatments now. There's ketamine, deep brain stimulation, ECT, and there have been models developed for each of those. There's only about 40% of the people who do well with ketamine, and you could actually predict it pretty well from information we know about them prior to starting the thing. Ditto with the others. If we can put together a thing that says, given all those profiles, which of these three, because I've got to do one of the three, which of those is most likely to be helpful in this case? That's in a world where we're flipping coins otherwise, a little bit of information is better than no information.
But that's predicting treatment response, not suicide. Do you know what I mean? It's a fundamental difference and a really important one.
Yep. I see there's a few questions in the chat that I want to make sure we get to just to honor our audience, and putting a few together for Dr. Bird. Might prediction information be more useful for earlier career clinicians with less experienced clinicians? And might we think about combining a few questions? Might we think about treating these like lab values and other areas of medicine where a clinician will look at a lab value and then incorporate that into their clinical decision making? Any comment?
Sometimes you wish you didn't have the lab value, to be totally honest, because sometimes it's a red herring and then you have to respond to it. But yes, I think as I typed into the chat in response to that, I think potentially yes, but I don't feel like we're quite there yet in being able to offer any model as guidance to somebody who is still learning. I mean, ultimately, this is pattern recognition, and a machine will learn it, or you will eventually learn it. Maybe in conjunction, we can learn it faster and better.
Great, thanks. And I wanted to also, in the interest of trying to synthesize and get us on the same page, there's some really creative new work. There's a researcher at Wellesley, computer scientist named Yaniv Jacobi, who's doing work trying to integrate clinical wisdom into machine learning models that use electronic health record. I'm wondering, especially from Nav, Suzanne's perspective, would that help assuage some of the concerns you have if there is a way, and this is work in progress, a way to get that kind of information in? So we're not just saying, is it man versus machine, so to speak, but how do we integrate these two in a way that makes use of what the clinician knows that's outside the medical record about homelessness and vibe and family concerns and so on?
I think it'd help you sell it, Matthew, to the clinicians if you're saying, "Look, we're going to take your views into account as well." Whether it's going to, again, make a transformative change to the models, I'm kind of not sure. For me, all of this stuff in the end has to be an adjunct. So it's you've got to say, look, it's the clinicians that make the decision here. And I really like the point about, could this be used as a training aid? It troubles me when I start kind of having thoughts that argue against myself. But, just thinking in the webinar about, what about the troubling variability of clinical services? Does some of, this machine learning stuff, does algorithm stuff have a role in that? So I think they are potential areas where it could be helpful.
I'm just noticing we've come to the end of this hour, which I have to say was maybe the best hour I can remember spending in a long time, just in terms of the richness of the content and the quality of the discussion about issues that are so vexing. So as you set it up in the beginning, Matt, bringing these folks together has really deepened our thought about this. And, I think this is such an important area. It's one we're going to see much more of. The thoughtful comments by the panel and have been phenomenal. And I'm really grateful that everybody has, I know Matt and I are, as is the whole center, very grateful that so many folks came today. And please do look for further events that we may host. Thanks so much to our panel. And let's keep working on this really, really important issue. Thank you all.
Thank you all so much.
Thanks. It was great. Thank you.
Bye.